today we are going to talk about wound care. Specifically today I want to address the ICD-10-CM codes as well as PCS codes. I want to talk a lot about documentation, and we are also going to address CPT coding for debridement. Now, I realize for those of you who are coding wound care in a hospital setting or a clinic setting, you go a lot beyond debridement, and we will be developing a part 2 to this presentation. I believe we're going to be offering that in an on-demand version because there's a lot more to discuss beyond the hour that we have for today. So today, again, documentation elements, talking about ICD-10 codes, a lot about pressure ulcers and non-pressure ulcers. We'll touch a little bit on burns and some of those other things, and excisional and non-excisional debridement, and as well as debridement versus active wound care management in the CPT setting. And hopefully this will address some of the issues and some of the reasons that you're tuning in today. We're going to get started and talk about documentation because this is going to be an area of coding where we really go above and beyond the documentation that we need just to code. If you are coding for Medicare, you want to be aware of any Medicare policies that are out there. Specifically, WPS and Novitas have LCDs related to wound care, and I would also recommend checking out Medicare's coverage database. They have a couple of, not NCDs, but they have some coverage memos that are in there that can help you with documentation. You want to be able to justify your codes if you are ever in an audit. And some of the information that your carrier, your Medicare administrative contractor may be requesting are not things that can be reported through codes, and they will request records, and you will need to be able to back up what is being reported. A couple of things. You know, it's pretty easy to get an order that has ulcer or whatever and code that, but we really need to go a little bit beyond that. You know, what kind of a wound are we talking about? And as Kathy was talking before the presentation about how we've got all these different kinds of wounds, and defining what those wounds are can be pretty tricky. Well, today we're really talking about those chronic wounds, or the wounds that are not healing very well, that are going to require some sort of intervention. And the first one that comes to my mind is pressure injuries or pressure ulcers. And that's followed very closely by diabetic ulcers because it seems like those two kind of go hand in hand. Traumatic wounds. And with traumatic wounds, we need to have documentation about how the injury happened and when it happened, and that's going to help us to get our 7th character to show the encounter. And then there are the non-healing surgical wounds, which are really kind of a pain when it comes to coding in ICD-10-CM. I was encouraged to see at the Coordination and Maintenance meeting in March that they have introduced a proposal to create new codes for poorly healing or non-healing surgical and traumatic wounds. Unfortunately, it doesn't look like that would be hitting until October 1st of 2018. But when all your physician tells you is this patient has a wound, you're really left to code just a traumatic wound, and that could open us up to some payment difficulties. You also need to know the location of that wound. That's going to help with specificity. We know how much our payers really don't like non-specific codes. Make sure that your physicians are also including laterality. Even though we've been in ICD-10 now for close to 2 years, we still see physicians forgetting to document that, that sacral ulcer was on the left side or it was on the right side or whatever. And stage or depth is important for our pressure ulcers as well as our non-pressure ulcers. We need to know just how deep that wound goes, and that should also help with some of the medical necessity for showing that wounds are improving. Now, where we need to go above and beyond, and what you'll see in some of these Medicare policies, are very specific criteria about how that wound is healing. And you need to be able to show through the documentation that this wound is healing, it is progressing. Otherwise, it is not considered medically necessary to keep doing the same thing when it's not working. And that's what a very generalized summary of what the WPS and the Novitas LCDs say is there needs to be objective evidence showing that this wound treatment is effective. And if it is not, then they need to modify the treatment plan. So the things that you need to have are the wound size, and that needs to be documented every time the patient is being seen. And what I've seen in a lot of wound care clinics is we've got electronic medical record documentation that is being copied and pasted forward, and we're not really seeing a progression. We just kind of see, oh yeah, the patient has an order for wound care because they've got a pressure ulcer, and you know, they just kind of carry that information forward. Well, several of the MACs are saying that that is not okay. We really need to be showing improvement. So wound size, length, width, and depth, showing that there is some of that healing from the outside in and from the bottom up. They also need to know any characteristics of the tissue within the wound bed. Is there necrosis, is there granulation, or is it infected? They also want to know if there's drainage or exudate and what kind or how much of that there is, as well as the condition of the skin that surrounds that wound. What does it look like in general? A couple of subjective things that could also be added into documentation to help to strengthen the medical necessity for doing these wound care procedures are to document how much pain that patient is having and the characteristics of that pain, including location, duration, intensity, and quality. And again, as I was saying, the wound healing progress, pictures are definitely something that can help with that, and I think for any of you who code for wound care have seen the pictures in the chart, and they're really kind of gross if they're very deep wounds, but it is, in some of those pictures you can see that healing process and show that it is improving, and that would be something you could provide to an insurance company if they are challenging you. You also want to know what the treatment plan is, including any of those changes to the treatment plan in order to treat a condition that is not improving based off of the former treatment plan. And then again, patient and caregiver education, whatever they're telling the patient to do to help improve that wound when they're not in the wound care clinic. I think that this isn't the kind of thing that we're going to see necessarily in the inpatient setting, but we're going to see a lot of this in the outpatient setting with our wound care clinics. When it comes to that physician order, just a couple of notes about what that order should include and whether this is a computerized order entry or a written order from the physician. We need to have something from the physician that identifies the patient as well as the physician who is ordering the service, that date of the order, and the start date of therapy if that's different from the date of the order, and the diagnosis. And again, the diagnosis should be specific. That term wound is just so vague. And if I look that up in the code book, what do I code? It gives me a default of a traumatic wound. And this could be a patient with a diabetic ulcer or a pressure ulcer. We need physicians to really give us that cause and any underlying conditions that go with that, so we can be sure to code the diabetes or the vascular insufficiency or whatever type of wound it is. That's going to help you with your medical necessity, because some of the insurers are really looking for something very specific, that vascular insufficiency with the ulcer or the pressure ulcer or what have you. And of course, the physician needs to sign and date that order. And those are just a little extra information for you. Hopefully we have orders for all of these, but you'd be surprised at what we see in the consulting industry when we go into different facilities. So we are going to start talking, well, I guess we've already started talking. We're going to continue on with diagnoses in wound care and addressing the CM codes. And there are a couple of guidelines that I wanted to point out here. The first one, I feel like every webinar I do these days talks about this guideline from section 1.A, and it has to do with the WIS convention. At this point, I think you kind of have to have been sleeping under a rock for the last 8 months in order to not know that this is has been an issue. But right now, that term WIS in the index assumes a cause and effect relationship between the two conditions that are listed within a diagnostic statement. And the best example here, of course, is with diabetes. So if you look up diabetes, whatever type we have, then we'll actually go to the next slide. Diabetes, you'll see this example actually shows foot ulcer indented underneath the subterm WIS, which is immediately beneath the diabetes main term. And that means that the coding classification system makes the assumption that if the patient has diabetes and also has a foot ulcer, that it is a diabetic foot ulcer. I will also say that this list continues down. Obviously, there are a million conditions listed under WIS, under diabetes. Skin ulcer, NOS, or NEC is also listed there. So anytime you have a patient with diabetes and a skin ulcer, you can make the assumption that it is a diabetic ulcer. And again, I've heard several coders, for those of us who've been coding for a long time, this is so uncomfortable because we're so used to querying these. And I've had coders come to me and say, I can't do this, it's diagnosing the patient. And you're not diagnosing the patient, the coding system is already doing it for you. So don't worry that that's going to come back on you. This is proper coding since they went ahead and changed this coding guideline for us last year. And that is going to lead us into our first polling question. Kathy, would you lead us through the polling question, please? Kathy, are you there? I'm not hearing Kathy talk. Okay, I don't hear Kathy, so I'm going to go ahead and read the polling question. It looks like the poll is up. So true or false, diabetes and foot ulcer have an assumed linkage. Is that true or is that false? So go ahead and make your selection. And Kathy's running the poll for us. So Kathy, we lost Kathy on audio, but okay. Looks like she shared the poll results, and the great majority of you said that the answer is A, true, and a few of you said that it is false. This one is true because of that new WIS convention that went into effect about a little less than a year ago, I suppose. So yes, diabetes and foot ulcer have that assumed linkage, and you don't have to query the physician. And Kathy can't hear me, so let me tell her to switch us back. All right. There we go. All right, a little bit of a glitch there, but we're going to move right on to the next coding guideline that I would like to address. And this is for the coding of burns and corrosions. particularly if you have a burn unit in your facility, you may be doing some procedures for these, or perhaps you have patients who had burns, they received all their active treatment, and now they're coming back later. There are coding guidelines specific to burns and corrosions, and they talk about the difference between a burn and corrosion. Burns are due to thermal injury, except for sunburns, which are coded elsewhere, and a chemical burn is considered to be a corrosion in ICD-10. So coding and sequencing of multiple burns. This slide, by the way, really just touches on the highlights from this guideline. It's a pretty long guideline. I do recommend that you go and you read this guideline if you're coding these. For me, this is not an area that I code often. So for me, if I came across a chart, I just have to know that I need to go back to the guidelines. So if you're not doing these all the time, tuck it away in the back of your brain as something that you need to be aware of in case you come across it. For coding and sequencing of multiple burns, we do want to code each site separately. I know that can be kind of a pain when you're coding multiple burns, multiple codes. But make sure that you code each site separately. And for each site, you want to code to the highest degree for that particular site. If you have one site and the physician says, there are second and third degree burns or first and second degree burns of this body site, then you're only going to code it to the highest degree. You don't code separate degrees for the same body site. Non-healing burns, which is something that you are likely to see in a wound care setting, are coded as an acute burn. And infected burns, you would use an additional code for the infection, whether it be cellulitis or something else. Okay, moving on to our next slide and talking about one of our favorite things, which is seventh characters. Seventh characters for active wound care burns. First of all, there is a coding guideline. It's 1.C.19.A that talks about the application of seventh characters. And there are several coding clinics that address seventh characters. There was one article in second quarter 2016 that addressed the seventh character assignment for physical therapy and home health encounters. And it talked about a patient who was referred for outpatient physical therapies 10 days after discharge for treatment of an acute burn. And he had third-degree burns of the right and left lower leg, and they talked about what the cause for that was. The patient was getting physical therapy for wound care, and they wanted to know what the seventh character should be. And this has got to be the best and worst quote from Coding Clinic ever. And this is a direct quote: active wound treatment is active treatment. Well, that clears it up, doesn't it? The bullet points that I listed underneath that, the surgical treatment, ED encounter, and the evaluation and continuing treatment by the same or a different physician, that terminology used to be in the coding guidelines, but it was removed from the coding guidelines for 2017. And I think it kind of helped, with the exception of maybe that third bullet point that talks about evaluation and continuing treatment by the same or a different physician. But what they're really trying to say is that active wound care, that initial encounter, that seventh character of A, is applicable when the wound itself is still receiving active care. It doesn't matter if the physician saw the patient once or twice or 6 times, or if this is a new physician and it's the first time they're seeing them for this injury. It has to do with what kind of, how that wound is being treated. And for physical therapy, since this patient had just been discharged and they were going to an outpatient or home health physical therapy then it would be considered to be active treatment. I'd highly recommend that you pull up this coding clinic and read it if this type of situation applies to you. Another guideline, and this one I think we're all pretty comfortable with, it has to do with documentation for deaths of non-pressure ulcers and pressure ulcer stages. We can have documentation from non-physicians indicating the ulcer stage or the depth of the ulcer. It's, as you can see from my graphic here, it's completely okay that Nurse Nancy is telling me that we have a stage 3 pressure ulcer. However, this is not enough documentation on its own to be able to code a pressure ulcer. We still need the physician to document pressure ulcer. But if he fails to tell us what stage it is, we can pull that documentation from our nursing staff or PT or any other non-physician care providers for that patient. And it looks like Kathy is back with us, so welcome back, Kathy. We have a couple of guidelines about pressure ulcers that evolve, and I'm talking about the acute care setting. And there is a coding guideline that says that if the patient is admitted with pressure ulcer that evolves into another stage during that admission, that you assign 2 codes. You assign a code for each pressure ulcer stage with the appropriate POA indicator. So the example I've given here is inpatient admission for stage 2 pressure ulcer of the sacral region present on admission, progressing to a stage 3 pressure ulcer midway through the hospital. And you'll see that I have assigned 2 codes, one for a stage 2, one for a stage 3. The stage 2 has a POA of yes, and the stage 3 has a POA of no. There is a little bit of a caveat, though. Let's talk about evolving pressure ulcers outside of the acute care setting. So the patient is no longer in the hospital. They might be in a nursing home. They might be in home health care. But in this case, we are only assigning 1 code, and it will be the code for the highest pressure ulcer stage. So the example I've given, home health encounter for stage 2 sacral pressure ulcer progressing to stage 3. During that encounter period, you only code the stage 3. And the reason for this is that the other guideline that I just mentioned on the previous slide is specific for assigning the POA indicator, and POA indicators are not applicable outside of the acute healthcare setting. Coding Clinic in first quarter of this year clarified that for us, that you would only apply that guideline in the acute care setting in order to capture the appropriate POA indicators. So healing and unstageable pressure ulcers. For healing ulcers, there is a coding guideline that talks about how to code for a healing ulcer. You code to the current documented pressure ulcer stage. So if you have a patient who is in inpatient acute care with a stage 2 pressure ulcer, but now it is a stage 1 while they're in home health care, for that home health care or wound care episode, it's going to be a stage 1 pressure ulcer. If the pressure ulcer was healed during admission, then you code the stage at admission. And I know I'm kind of going back and forth between inpatient setting and outpatient setting here, so if I'm losing you on anything, just send a question through the chat window and I'll make sure to address those. Unstageable ulcers also have a coding guideline, but a note about unstageable pressure ulcers, that doesn't mean that you don't know what stage it is. It means that it is clinically undetermined. The physician can't tell what the stage is at that moment in time. It is not the same thing as unspecified. So we're really looking for documentation from the physician or a non-physician provider involved in that patient's care that says, you know what, we really can't stage this ulcer before you use an unstageable code. A you may have heard a little bit of buzz, you know, pressure ulcers are no longer pressure ulcers. We now call them pressure injuries. The descriptions that you see on the left side of your screen are the pressure injury stages. You'll also notice that there is a definition of what an unstageable pressure injury is. They define it as obscured full thickness skin and tissue loss, as well as a deep tissue pressure injury. On the right side of your screen, you see an image for the stages of a pressure ulcer, which actually match up with stages 1 through 4 of pressure injuries. They are considered to be the same thing. This was addressed in coding clinic of third quarter from last year. And just a note that those are effective with discharges as of September 23rd of 2016. But pressure injury is the same thing as a pressure ulcer. And if you have documentation of a stage 2 pressure injury, you code a stage 2 pressure ulcer. And that was fixed in the coding index for fiscal year 2017. So if you look under injury, deep tissue, meaning pressure ulcer, it will lead you to your pressure ulcer code. And that leads us to our next polling question. Kathy, can you open up our next polling question?
I sure can, and I am back, and I apologize for that. All of a sudden, my phone went completely dead, you know, and you talk about pressure ulcers. I was under a little pressure there for just a second, but I am back. So for this polling question, the question is, inpatient is admitted with stage 2 pressure injury on admission, progressing to a stage 3 during stay. What stage do you code it? Do you code it at stage 3, stage 2, both stage 2 and stage 3, or 2 plus 3 equals stage 5? So what do you think? I like that, Christy. 2 plus 3 equals stage 5. So we've got some responses coming in. It looks like we're going to have some good discussion. So yes, keep coming in. I've got 70% of you who have voted. Anybody else want to kind of ring in? We're going to have some discussion, so we don't have people that all agreeing. So don't be shy. Let us know what you think. Okay, I am going to, yep, we've got a few more people. I'm going to close the poll in 3, 2, 1. Christy, our responses, we have 25% of our audience feels it's a stage 3. We have 6% who feel it's a stage 2, and we have the majority at 69% say both stage 2 and stage 3.
And nobody said 2 plus 3 is 5? After you mocked my choice there? Okay, so this one, for everybody, the 69% of you who said that the answer is C, it is both a stage 2 and a stage 3, that is the correct answer for this inpatient. Now remember, the healthcare setting has everything to do with how we code this. If this had been somebody who was sent to post-acute care, the answer would be A. In order to get our POA indicator for our inpatient acute care, we need to report both stages with the POA indicators of yes and no. All right, good job. Thanks, Kathy. Can you bring us back to our presentation, please? Thank you, ma'am. Okay. Moving on to complications of surgery and other medical care, there are some coding guidelines about how to code for complications. And I'm sure that you're seeing some of these patients in your wound care clinics or outpatient, wherever they may be coming from, where they have had some kind of a procedure. They are getting wound care for a condition that is a complication of that surgical care. And the example I've given here is MRSA infected post-op wound following open reduction internal fixation for a right distal radius fracture. In that case, your T code for the complication is going to go first because it is the reason the patient is getting the wound care. Remember that if you have an infection associated with any of your wounds. You want to make sure to code that organism if it's specified. We have a code for the MRSA. And then finally, because this was for a post-surgical infection, I'm also going to add the code for the fracture, but the 7th character on my fracture is a D because that is in the healing process, unless you have documentation saying that something else is going on, but that is in the healing process. And notice my complication code has a 7th character of A because the complication is receiving active wound care treatment, and those two don't have to match up. We're talking about two different things, a complication versus an injury that is already in the healing process. A couple of things more about diagnoses before we get into the good stuff about procedures. Just make sure that you are aware of your billing policies and within your facility. Most wound care clinics who are doing outpatient services bill on a recurring basis with 30-day stays, usually going from the first of the month to the last day of the month. You may also have individual encounter billing. Now, I've had a physician tell me, okay, I document the diagnosis for that first day of that recurring billing period. Well, that's great, but you need to show progression throughout that month of that wound. So you can't just have a physician copy and paste forward. I had one physician tell me, what's the point of having an EMR if I can't just copy and paste stuff forward? And I don't know what look I had on my face, but inside I was screaming and thinking that's not the point. You know, we need to be able to show that this patient's improving. Watch for unspecified diagnoses. We know that payers don't like them, and payers are looking for any excuse to deny a claim. We can try to head them off at the pass by getting as specific as possible. And code only what's being treated. Remember your coding guidelines for additional diagnoses. In the inpatient coding guidelines, they're found in Section 3. For the outpatient and physician settings, they're found in Section 4. And don't treat things that were treated and resolved during an inpatient admission. Another thing that you may want to take into account is the patient's smoking history. Is the patient a current or a former smoker? That will impact wound healing and should be reported. Also, if there was any smoking cessation counseling done during your encounter, that should be coded as well with a Z code. There are some of the LCDs that will define who can provide wound care services, and any physician obviously can provide wound care services, but depending on licensing requirements for your state, you may also be seeing nurse practitioners, physician assistants, or clinical nurse specialists performing these procedures or this type of wound care. So again, be aware of your state licensing and also be aware of what your payers say about the different providers who can provide this treatment. Couple of etiologies of ulcers. Remember that diabetic ulcers are linked. Diabetes and ulcers are linked, so you're going to report an E code for that. Non-pressure ulcers are going to code to the skin and subcutaneous section or code to begin with the letter L. That includes patients who are having any kind of vascular disease, but you will notice that there are notes for those to code first any associated underlying conditions. In the example that we have here, the right heel ulcer down to and including the fat layer due to arteriosclerosis. And that requires a code for the arteriosclerosis, which does say that it is an ulcer, or yes, an ulcer, but then it doesn't say specifically where it is. You need to add the L code to show the location and laterality of that particular ulcer. Moving on to CPT coding for debridement. Before I launch into my procedure discussion, we're going to go through CPT and then we're going to talk about ICD-10-PCS. And just a reminder that CPT is from Mars, ICD-10 is from Venus. The coding rules are different. You cannot cross the two. If you are reporting both in the outpatient setting, both a CPT and a PCS code, you need to make sure that you're applying the coding guidelines separately. If you're using an encoder, you need to be particularly careful. A lot of the encoders will lead you to the correct CPT code but the wrong PCS code, or vice versa. And it might require you opening a code book to verify the code assignment. CPT and some of the payer policies do talk about the types of wound healing, things that are applicable only to wounds that are healing by primary, secondary, or tertiary intention. In case you want to know what those mean, that is listed for you here. So wounds that heal by primary intention are those that are stapled or sutured closed. That's typically what we see for traumatic wounds in the ED. Wounds that heal by secondary intention are those where the wound edges cannot be approximated. There's either been an avulsion of skin or ulceration, and so this wound is left to heal from the outside in. Most of what we see in the wound care setting is going to be for wounds that heal by secondary intention. If you think of those ulcers, we're really just trying to provide the best healing conditions possible in order for this wound to heal without being able to suture it closed. And tertiary intention, we are not going to be discussing today. Those are those wounds that heal by delayed or secondary closure. So looking at the two banks of codes that we're looking at in CPT, we have codes for what they call debridement, 11042 to 11047, and then they also have active wound care management, 97597 to 97602. And it can be confusing because those active wound care management codes include the terminology debridement. So how do we tell the difference between these two? The excisional debridement codes that are found in the integumentary section, the codes that begin with 1, are mostly for acute wounds. These are measured in total depth and surface area, and we are able to code for debridement all the way down to the bone. Whereas active wound care management is usually what we'll see in the wound care clinic setting. These are chronic wounds. They are measured in surface area, and the depth is usually not below the skin level. So if it's below the skin level, you're probably looking more at your integumentary codes for excisional debridement as opposed to these active wound care management. And with the active wound care management, it's not a one-and-done procedure. These are patients who are going to come back and receive continuing care. Let's focus first on the code from the integumentary system for debridement. And this is a sharp excision of tissue down to and including viable tissue. And they're really looking at taking those margins. This is a procedure that is typically done in the OR under anesthesia by a physician. And you're going to code by the level of tissue removed as well as the size of the wound. And you see the codes with their specific code descriptions listed out on this slide. The codes that have the pound sign or hashtag, I guess, I just showed my age, the hashtag in front of the code, those are out of numerical sequence in the CPT book. Just be aware if you are using a book as opposed to an encoder that they might take a little bit of extra legwork to find. And you'll see that we have debridement of, or 11042 is debridement of subcutaneous tissue for the first 20 square centimeters or less. The 11045 is each additional 20 square centimeters or a part thereof. So if they do 30 square centimeters of the subcutaneous tissue, you code 11042 and 110451. It doesn't have to be the full additional 20 square centimeters. It's up to an additional 20 square centimeters. And then the other 4 codes listed there are set up the same way. They're just for deeper structures. We've got the muscle and or fascia, and then we also have bone. So here's an example for you. A diabetic patient with a 4 by 3.5 centimeter posterior heel ulceration involving skin and subcutaneous tissue, and Achilles tendon and muscle. Excisional debridement of the wound was performed down to and including the tendon and the muscle. And what great documentation this physician gave us to tell us that not only was it down to, but it also included tendon and muscle. In order to get our square centimeters on this, we're going to multiply the 4 by the 3.5 centimeters, and our final code assignment ends up being 11043. Now, the active wound care management is limited to the surface area only. It includes removal of the non-viable tissue, so going all the way down to above where the tissue is viable. And this, again, usually doesn't go below skin level and can be repeated as many times as we need to. Of course, your payers may not pay for it if the wound is not improving. They'll expect you to adjust the treatment plan and do something different. And the active wound care codes include selective and non-selective debridement. So for the selective debridement codes, we have 2 codes, 97597 and 97598. And again, no viable tissue is removed here. They are removing this tissue. They may be excising it. They might be using a high-pressure water jet. They might be using scissors, scalpel, or forceps. Any kind of removal of only that non-viable tissue. So non-selective debridement is the gradual removal of non-viable tissue. This is usually not performed by a physician and is something that we're likely to see in the wound care setting. And the types of debridement we'll see here are blunt debridement, enzymatic, autolytic, mechanical, chemical, or biological. Something that they do other than cutting away that tissue in order to remove that non-viable tissue. So the example we have here is a patient who presents for follow-up care, pressure ulcer on the left plantar heel. The wound measures 4 by 3 by 1, and this patient previously had extensive debridement. Now the wound edges and the wound bed are viable with granulation but covered with adherent floss, fibrin, and debris, and the patient is scheduled for selective active wound care management. Now, does this look like your documentation? If this doesn't look like your documentation, then you might have a problem, and you probably are going to need to work with your physician. I realize this is a lot of description, but this is what is going to make it possible for us to code our selective removal of our non-viable tissue. This happens to be a 12 square centimeter wound, and the code assignment is 97597. For multiple wound debridement, first of all, remember you're reporting the depth of the debridement, not the depth of the wound. So the depth of the wound will be coded with your ICD-10-PCS code, but the depth of the debridement is coded with your CPT code. So single wound with multiple depths, you're going to assign a single code for the deepest level debrided. If you have multiple wounds of the same depth, you're going to add all of those wounds together to get the total surface area. And multiple wound sites with different depths, you're going to code to the deepest level for each debridement site with the appropriate square centimeters. And then make sure that you use modifier either 59 or XS if your payer accepts it in order to satisfy your column 2 NCCI edit. And that's going to lead us to our next polling question. No, it's not. Sorry. Not there yet. Just a note about E&M codes. For those of you who are reporting the hospital clinic level E&M, you can assign an E&M code in addition to the wound care codes. However, you need to have very clear documentation that that E&M is related to something other than what they're receiving the wound care for. It could be a new ulcer or a new area of concern, but make sure you have good solid documentation to back that up, and you'll assign that modifier 25 to your E&M code. Okay, now we're going to do a polling question. Kathy?
Perfect. Okay, so the question is, which CPT codes are used for excisional debridement of the tendon in the wound clinic? And I'll let you read those codes because there's several choices. So which CPT codes are used for excisional debridement of the tendon in the wound clinic? What do you think? Well, you guys are fast. We've got people, ooh, keep rolling in the answers. Oh, I had a great response last question, so I'm going to just kind of sit it out, wait it out. Don't be shy. This is what leads to great discussion. So wonderful. Yep, still waiting. Answers are rolling in. We're going to have some good discussion, so don't be shy. What do you think? Which CPT codes are used for excisional debridement of the tendon in the wound clinic? Okay. Okay, Christy, I think we have some shy voters on this one. I'm going to go ahead and close it, so we're going to have some great discussion. I'm closing. Sharon. And Christy, since the answers kind of rolled in a little slow, I think we have some hesitancy here. We've got only 8% who do feel the third choice is correct, the 11055 to 11057. And we have the majority at 92% are saying it's the last one, 11042 to 11047.
Okay,
what
thank
do
you.
You bet, Christy.
I think there was, I could sense some hesitancy on this one. This one is kind of a trick question. Now, I talked about the wound care clinic mostly being active wound care management, which would be the 90,000 codes. But remember that those don't go any deeper than the skin level, and this was excision of the tendon. So for this one, and it kind of requires you going back a couple of slides and remembering what that code range was. The answer is C. It's the 11042 to the 11047, and that is the codes for debridement in the integumentary system. Good job. Will you bring us back into our PowerPoint, please, Kathy? Thank you. A couple of notes for those of you who are doing procedures for burns. There are some CPT codes that are specific to debridement of the burns. And what I've given you here is a list of the codes with the descriptions and then an explanation of what they're being used for. You'll notice that the 16,000 is really just simple cleaning and ointment and dressing application. You probably won't be using that a whole lot in the wound care. I don't think first-degree burns typically require wound care treatment. But then you have the 16020 to 16030, which includes any debridement that is done of a burn site. And then if there's an eschar, which is a thick leathery slough that occurs over a thermal burn, we do have codes specifically for escherotomy where they incise into that to release some of that tissue. For assessing depth, CPT does look at superficial burns usually require local treatment, and partial thickness burns, and that is shown with this image on the left here, usually require more debridement. With CPT for burns, they also employ the rule of 9s. If you have a CPT code book, I know it's in the professional edition, they show an image of the rule of 9s, but we have provided it here for you in case you don't have that. And it does show the percentages of body burn depending on the site. You'll notice that it is different for babies than it is for adults because their heads are larger and cover a larger amount of space. So surgical preparation, I included this because I don't want you using this with your debridement codes. This really relates to wounds that heal by primary intention, and we're primarily coding procedures for things that require secondary intention healing. So just a note about that before we move on to ICD-10-PCS coding. So the biggest thing that I want to tell you is that selective and non-selective debridement are CPT terms. They do not exist in ICD-10-PCS. which is another reason for your physician to be very, very specific about what kind of tissue he removed and how he removed it. That will help you get your CPT code as well as your PCS code. A couple of guidelines that are important when it comes to debridement. The overlapping body layer guideline just says that if a procedure is performed on multiple layers in the musculoskeletal system, you only code to the deepest layer. For example, if the patient had debridement of skin, subcutaneous tissue, fascia, and muscle, you're only going to code it to the muscle. There's also a coding guideline about the skin, subcutaneous tissue, and fascia that overlies a joint and which body part that would code to. When it comes to coding in PCS for debridement procedures, it's all about excisional versus non-excisional. For excisional debridement, it codes to the root operation excision, and the definition is listed here as well as a translation. Now, what we are constantly telling people is don't get hung up on the instrument that was used to perform the debridement. You need to be hung up on how that instrument was used. So they used a scalpel. Well, did they cut with the scalpel or did they scrape? Cutting is excision, scraping is not. A non-excisional debridement codes to the root operation extraction, which is pulling or stripping off. And again, this is removal of tissue without cutting, and that would include scraping with a scalpel. There are a couple of things that have come up with in coding clinic when it comes to coding for excisional versus non-excisional debridement. And basically what the coding clinic has said is if it meets the root operation definition of excision, which is cutting out or off, that you can code it as an excisional debridement. So code excisional debridement when devitalized tissue is cut away. You can code excisional debridement when the doctor says it was excisional debridement, and again, if the procedure meets the definition. Now, you don't code excisional debridement when they're scraping the wound with a scalpel or for minor removal of loose fragments with scissors. And then, of course, coding clinic always tells us if you're not sure, then query the physician. And they love getting queries about debridement. So I'm sure they'll be more than happy to answer those questions. The problem that we're seeing with non-excisional debridement, and this is something that we identified at Haugen Group, I don't even remember how long ago, but we sent in a couple of letters, and finally they gave us an answer on this. There are body systems that do not have extraction tables. So if they did a non-excisional debridement of the muscle, tendons, upper bones, or lower bones, we have nothing to code. And the question was, how do we code for this? Coding Clinic did address that in third quarter of 2016, and they said to code it to the closest available body part equivalent, which is the subcutaneous tissue and fascia. So you're going to forego the body part in order to get the right root operation. And the reason that they do that is excisional debridement codes to a surgical DRG, whereas non-excisional debridement codes to a medical or a non-surgical DRG. And the differences in payment are huge. Now there is a proposal, and actually the codes are out for October 1st of 2017, and I believe they have added extraction tables to these 4 body systems that are listed here, and that will solve the problem for all of us, so then we won't have to worry about it. Just a note about VersaJet hydrosurgical debridement, if this is something that you do, it utilizes a high-velocity stream of water to remove the tissue, and I kind of think of it like a water pick. If you have ever used a water pick and watched the water stream out there and maybe felt that on your hand, it's even higher than that, to the point where it can strip off some of the tissue. And this codes to a non-excisional debridement according to Coding Clinic. So just know that coding for debridement is a compliance target, if you didn't know that already, because of the way that it groups sending the excisional debridements to surgical DRGs and the non-excisional debridements to non-surgical DRG. You also want to be aware of payer documentation requirements for debridement. If they say sharp debridement, that doesn't really tell me anything. I need to know what was done with that sharp instrument. Was something cut away? So focus on what was done with the instrument rather than the instrument itself. And I think, Kathy, in the interest of time, we'll skip this last polling question. And just a quick summary to summarize everything up for the day. Don't forget to document, work with your physicians to get all that documentation about the wound and all of that specific documentation about the procedure. And remind them that the whole point of this is to be able to see progression and healing of the wound. That we're not asking for this information for ourselves. We are trying to make sure that everybody gets paid appropriately, the hospital, the physician, everyone. And that is going to do it for me. I did want to point out on the reference page on your presentation that I've listed out the Novitas and the WPS LCDs on the bottom of this page. You can just Google Novitas L35125 and it'll pull that one up, as well as the other references that I used.